Thank you, Chairman Buchanan and Ranking Member. And thank you all for being here today. 1.2 million people in West Virginia have at least one chronic disease, and 527,000 people have 2 or more chronic diseases. In a state of only 1.7 million people, these numbers are staggering and concerning. Not only are they alarming from a public health perspective, but they also worry me from a fiscal perspective. Patients with multiple chronic diseases cost the healthcare system more money to treat and cost West Virginia more than $10 billion annually in medical costs. The most common sense way to help combat the chronic disease epidemic is through education, screening, and prevention. I specifically focus much of my work on kidney disease, and I recently became the co-chair of the Congressional Kidney Caucus with my fellow Ways and Means member, Susan Delbene. Chronic kidney disease is also known as the silent killer because it can progress for years without any symptoms. If left unmanaged, chronic kidney disease will progress into end-stage renal disease. And this disease can only be handled by surgery or continual dialysis. Dialysis is extremely expensive for the federal government and very taxing for patients. ERSD affects only 1% of Medicare beneficiaries, but it accounts for 7% of Medicare spending. Managing dialysis can be particularly difficult for patients in rural areas. Just finding transportation to the nearest dialysis facility and then spending several hours on the machines, the travel, the treatment, it's very burdensome for people who don't feel very good anyway, and they're living in rural communities. While increasing access to services such as home dialysis can help patients manage their disease, life can be made much easier if a physician or a nephrologist can identify a patient with chronic kidney disease early on. Dr. Carlson, you know firsthand that early screening can reduce costs and improve outcomes for patients. Could you speak about how early screening can affect long-term health outcomes for patients with a chronic disease?
Yes, ma'am. Thanks for the question. So, again, there's great evidence that says that early diagnosis, early intervention is going to have improved outcomes at less cost. Chronic kidney disease is present in about 15% of adults, and about a quarter of those then also have a family history. Our next-gen sequencing, these genomics assays, are widely utilized for pediatric nephrology, but are rarely used in adult nephrology. I think that for chronic kidney disease in particular, that there should be a migration, a broader adaptation of some of the genomic assays that would be available for those patients to identify them and allow that earlier intervention.
Thank you. I've worked on legislation with Congresswoman Terry Sewell called Chronic Kidney Disease Improvement in Research and Treatment Act, and it expands the Medicare annual wellness benefit to include kidney disease screening. It also increases access to the Medicare kidney disease education benefit, which will enable physicians to teach their patients about managing their disease and any comorbidities they may have. A recent study shows that compared to urban areas, rural communities have higher rates of cancer, higher rates of late-stage cancer diagnoses, higher cancer deaths. And the urban-rural gap is not getting better. It's steadily widening over the last decade. Rural areas also have lower reported rates of cancer screenings for colorectal, breast, and cervical cancer. Dr. Carlson, given your experience, can you tell us more about why rural communities are struggling with cancer?
So thank you for the question. A large footprint for Mercy is in that rural community. And they have, there are a lot of barriers, really, that one of them being transportation just to get in, that make it a challenge. The rural community can sometimes be a little bit uneducated, and that so that we appreciate the work that you've done in educating those patients. But I think some of it's also trying to figure out how to incentivize those patients that regardless of where they live or their financial situation, that we push them to get in. And some of the predictive algorithm work that we've done, we identify patients, and if you knew that your risk for colon cancer was 10 times higher than the average patient, it might push you to get the bowel prep and get a colonoscopy done. And so those types of things, I think, in addition to the other incentives that you've listed, will help incentivize the patient to take greater control of their own care.
Thank you, and I yield back.